Hello Dentospedia learners. In today's case study, we'll discuss another important high-yield topic for all dental board exams. We'll move step by step: history, findings, investigations, questions, and exam tips. Here is your clinical scenario for this case study. Refer to this information for questions 1 to 5. David, a 24-year-old university student, reports to the dental emergency clinic complaining of severe gum pain and bad breath for the past 3 days. He says his gums started bleeding spontaneously, and he now finds it difficult to eat. Medical history reveals recent prolonged stress, poor diet, and irregular sleep. He admits to smoking 10 cigarettes per day. He has no systemic disease, but reports significant weight loss during exam season. On clinical examination, there is punched-out, crater-like necrosis of interdental papillae in the anterior sextant, with a gray pseudomembrane, spontaneous bleeding, severe halitosis, and pain on probing. No deep periodontal pockets are detected. Vital signs, low-grade fever, 38 degrees Celsius, and cervical lymphadenopathy are present. Let's have a quick breakdown of the patient's profile: age, gender, chief complaint, and medical history. In this case, the anterior papillae show punched out, crater-like necrosis covered by a gray pseudomembrane. The patient has severe halitosis, spontaneous bleeding, and pain on probing. Importantly, no deep periodontal pockets are present. Systemically, he shows a low-grade fever and cervical lymphadenopathy. Now that we've reviewed the case history, findings, and investigations, let's test ourselves with some interactive questions. I'll show you the question with 4 options, give you a few seconds to think, and then we'll reveal the correct answer with explanation. Question 1. In this patient, which feature most reliably differentiates necrotizing ulcerative gingivitis from necrotizing ulcerative periodontitis? Option A, severe halitosis. Option B, spontaneous gingival bleeding. Option C, absence of clinical attachment loss and periodontal pockets. Option D, presence of pseudomembrane on the gingiva. Take a few seconds to think. The correct answer is C, absence of clinical attachment loss and periodontal pockets. Why? Necrotizing ulcerative gingivitis is confined to the gingiva and interdental papillae. It causes necrosis and pseudomembrane formation, but there is no attachment or bone loss. Once the lesion extends into the periodontal ligament and alveolar bone, it progresses into necrotizing ulcerative periodontitis, which does present with attachment loss and deep pockets. Now let's look at the distractors. Severe halitosis and spontaneous bleeding can occur in both NUG and NUP, so they do not differentiate the two. The pseudomembrane is also common to both conditions and therefore not diagnostic by itself. Question 2. Which factor most likely triggered David's condition? Options are A, poor plaque control alone. B, recent stress, smoking, and malnutrition. C, underlying undiagnosed diabetes, mellitus. D, viral infection causing immunosuppression. Pause for a few seconds and think. The correct answer is B, recent stress, smoking, and malnutrition. Why? Necrotizing ulcerative gingivitis is strongly linked to predisposing factors that suppress host defense. In young adults, exam stress, tobacco use, poor diet, and irregular sleep are classic triggers. These allow fusospirochetal organisms to flourish. Now the other options. Poor plaque control contributes but does not explain the acute onset and severity on its own. Diabetes is a systemic risk factor for chronic or generalized periodontitis, not the typical presentation of NUG. Viral infections may predispose to immunosuppression, but they are not the main cause here. Question 3. Which initial treatment approach is most appropriate for this patient presenting with fever and painful necrotic papillae? Options are A, immediate full mouth scaling and root planing in one session. B, gentle superficial debridement with chlorhexidine rinses plus or minus systemic metronidazole. C, gingivectomy of necrotic papillae. D, extraction of affected anterior teeth. Take a few seconds to think. The correct answer is B, gentle superficial debridement with chlorhexidine rinses plus or minus systemic metronidazole. Why? In acute necrotizing ulcerative gingivitis, the tissues are extremely painful and fragile. The correct approach is to gently debride only superficial deposits to reduce bacterial load, prescribe antimicrobial rinses, and if there are systemic signs like fever and lymphadenopathy, add metronidazole. Definitive scaling and surgical procedures are postponed until the acute phase resolves. Now the distractors. Immediate full-mouth SRP is too aggressive and would worsen pain in the acute stage. Gingivectomy is contraindicated because the tissue is already ulcerated and inflamed. Extraction is not indicated unless a tooth is hopeless, which is not the case here. Question 4. Which microbial profile is most characteristic of necrotizing ulcerative gingivitis? Options are A. Aggregatibacter, Actinomycetum comitans, dominance B. Spirochetes and fusiform bacteria. C. Gram-positive streptococci and lactobacilli D. Candida albicans overgrowth. Pause and think for a moment. The correct answer is B. Spirochetes and fusiform bacteria. Why? NUG is classically associated with the Fusospirochetal complex, which includes Treponema denticola, Fusobacterium nucleatum, and Prevotella intermedia. These organisms thrive under stress, malnutrition, and smoking, when host defenses are compromised. Now for the distractors. A. Actinomycetum comitans is linked to localized aggressive periodontitis, not NUG. Gram-positive streptococci and lactobacilli are typical of healthy plaque or caries, not necrotizing conditions. Candida albicans overgrowth produces candidiasis, not NUG. Question 5. If David's necrotizing ulcerative gingivitis is not treated, what is the most likely clinical progression? Options are A. Necrotizing ulcerative periodontitis with attachment loss. B. Spontaneous resolution after 2 to 3 weeks. C. Transformation into chronic gingivitis. D. Secondary herpetic infection of the gingiva. Take a few seconds to think. The correct answer is A. Necrotizing ulcerative periodontitis with attachment loss. Why? Untreated NUG does not simply heal. Instead, it can extend into the periodontal ligament and alveolar bone. This leads to necrotizing ulcerative periodontitis, with irreversible attachment and bone loss. Now for the distractors. Spontaneous resolution without therapy is extremely rare. Chronic gingivitis is a different entity and does not arise directly from NUG. Herpetic infection is viral and unrelated to this bacterial necrotizing process. Management of NUG begins with gentle debridement, warm saline and chlorhexidine rinses, and analgesics. If systemic signs are present, metronidazole is prescribed. Once the acute pain subsides, we perform full scaling and give oral hygiene instructions. Long-term success depends on controlling risk factors like smoking, stress, and nutrition, and keeping the patient on supportive care at 3 to 4 month intervals. With prompt treatment, the prognosis is good and lesions heal without lasting damage. But if left untreated, NUG can progress into necrotizing ulcerative periodontitis, causing irreversible attachment and bone loss. Key pearls. Remember the classic triad of punched-out papillae, pseudomembrane, and halitosis. NUG has no pockets, unlike NUP. It's driven by fusospirochetal organisms, and the first-line treatment is gentle debridement with chlorhexidine, adding metronidazole if systemic signs are present. If left untreated, it will progress to NEP with permanent bone loss. Follow us on social media. Download our app Dentospedia on Play Store and App Store.